Hello everyone, welcome to this lecture. In this lecture we will focus on the application of these equation of EEG. Now until now what we were learning is the biopotentials, whether it was ECG or EMG or EOG or EEG, right, or even GSR, which is galvanic skin resistance. But in that we have taken EEG as one of the biopotentials because we are interested in the brain signals. But once you understand how the EEG can be acquired, the next thing is how to apply that understanding to solve a particular problem. Now here we have addressed a very important problem, which is epilepsy. Epilepsy is also called as a seizure and is also known as fit, right. So you may have seen someone, right, in your lifetime whose has his body has an involuntary movement, like he is completely shaking, right. Now, and it is in some cases so much that the person cannot control, and if he falls down or she falls down, and the only way we do lot of unscientific treatments, right. By sometimes I have seen people taking the leather and giving it up, or making the person smell that leather, assuming that the fit will suppress. But generally this epilepsy can be treated by taking anti-epileptic drugs, and there is something called intractable epilepsy, where the person has to go through the intraoperative surgery where the part of the tissue is resected. Now which part of the tissue is resected? The part that is misfiring electrical signals. But before that we need to first understand how the epilepsy or how the brain signals are obtained and how they are analyzed by the neurophysiologist. So in that direction, let me tell you that the time taken to record the signal would be somewhere around 45 minutes. So then generally the patient is asked to be sleep deprived. When the person goes into the sleep, from that time little bit before that to all the way to 45 minutes, the signals are continuously recorded using the 10-20 manner, right, where the electrodes are placed. We have discussed 10-20 ways of putting the electrodes. Number of electrodes is 21, right. So those electrodes will pick up the signals from different region of the brain, whether it is frontal or it is central or it is occipital or it is temporal, right, or it is parietal. So all these different regions, the signals are acquired, and then based on this particular channels and the signal, the way the signal will behave, the doctor can diagnose that whether the person has epilepsy or not. One. Second is, within epilepsy what kind of different subcategories are there. So there is something called absence seizure, there is something called focal seizure, there is something called generalized seizure, there is something called focal to generalized seizure, and then there is normal. So not only that the doctor has to identify it correctly, that means that no normal should be identified as epileptic, while in case of epilepsy also, if there is a better way to diagnose or subclassify or classify the seizures, right, whether it is focal or generalized or focal to generalized or absence, then it is very important. Why? Because based on that the treatment is generally given, which drugs to get, how effective it will be. So all these things are been are dependent on the way the signals are acquired and are diagnosed. So the question is that if these things are known, where is the challenge, right, where is a gap, isn't it? So the gap is that, like I said, a person needs to read entire 45 minutes of data, isn't it? It is cumbersome, and there will be human errors. How to reduce those errors and how to help the clinician to go to that particular time in that 45 minutes time stamp, and if this algorithm can help the clinician by telling that okay, first go to this time step between 10 to 15 minutes or 10 and 11 minutes or 10 and 13 minutes, just giving example. Okay. In that you can see the sharp, you can see the spikes, you can see slow waves, and you can see mixture of two. That means that according to us it looks like it is this kind of epilepsy. Let the clinician finally take a call. So, that tool will be a aiding, a tool that can aid a clinician, isn't it. So, can we design such tool? That is the focus of today's lecture, and you will see that we have designed it, and in fact there is a paper published by our group on understanding the signatures for the epilepsy seizure detection and classification. So, if you see the screen, the epilepsy, when we talk about epilepsy, let us talk about prevalence and consequences. First, epilepsy is a chronic neurological disorder of repeated seizures. Epilepsy can be described by seizures and syndromes. What is seizure? Seizure is nothing but temporary disruption of brain function due to abnormal and excessive neuronal discharges. Okay. So, this is because of the neuronal discharges. A seizure is nothing but like a electrical storm in the brain, alright. So, it is really if you do not take up the care of the seizure, it will really damage the part of the brain. So, seizure can take control of the brain, it may lead to dangerous fatal consequences. So, patterns of seizure is an important parameter for epilepsy classification, right. How the seizures are happening and when it is happening and what kind of signatures are there, if you can somehow diagnose or can measure, it will be useful. While when you talk about syndrome, right, because we have talked about epilepsy can be described by seizures and syndromes. So, what is syndrome? Syndrome is nothing but group of features usually occurring together, providing information about the onset, progression and site affected, age and genetical structure. Okay. So, all these things we can get it if you know this syndrome. Second is patient history plays a significant role in deciding future of this particular thing, which is the syndrome or feature of the epilepsy, and then epilepsy is more likely to occur in a brother or sister if the child with epilepsy has generalized seizures. Okay. Now, if you talk about prevalence, then more than 50 million people worldwide have epilepsy. You see, more than 50 million people. About 10 million people in India are suffering from epilepsy at present right now, right. And I think this is also very old data. If actually it is a way old data, not just Indian data, it is a way old data. So, this value would be way higher than 10 million. This was in 2014, right. I can find it out the latest data, but you can also find it out. My point here is that the number of people suffering from epilepsy is extremely high. Next is about 1 in 3 has a refractory epilepsy, that means the mortality rates are 4 to 7 times higher. So, it is estimated that 70% of the people living with epilepsy could live seizure free if properly diagnosed and treated. This is very important thing, right. 70% of the people can be treated effectively. Now, what are the consequences of this epilepsy, right? Prevalence is that we know that okay, these are the numbers, and if we can get some nice way to diagnose it at early stage or right way of diagnosis or correctly diagnosing the epilepsy will reduce the number of the fatal deaths that may occur due to the epilepsy. But what are the consequences of this particular disease? The consequences are, one is shortened lifespan, it reduces the lifespan of a person. Second is excessive bodily injury, because a person can suddenly fall, right, their person cannot control himself or herself. Next one, there is a brain injury, every time the episode occurs there is a injury of the brain. Neuronal death, right, physiological dysfunctions, reduce employment levels, right, because a person who has many episodes of seizures, right, difficult for the employer to hire the person because at any given time that episode may occur. Reduce marriage rates, right, and of course physiological psychological disabilities. The point is psychological disabilities. The point is that the correct way of epilepsy diagnosis is very important. So, as I told you, right, the epilepsy, if you can see, the frontal lobe is where your nose is, okay, nose, the forehead, and forehead below is this region, right, nasion, inion, if you remember, right. So, frontal lobe, then you have temporal lobe just above your ears, then you have parietal lobe, and then you have occipital lobe. Parietal lobe just at the back, if you draw a line like this, exactly the back is occipital lobe where you is used for visualization, and you have parietal lobe here just before the occipital lobe, and then you have a central region, and of course you have a cerebral lobe, right. So, this is the very simple way of showing the brain structure. Now, when the normal EEG is there, it looks like this, but when there is a generalized seizure, that means that it occurs anyway in the either frontal lobe, temporal lobe, parietal lobe, central, occipital, does not matter, anywhere it can occur, and it is everywhere it is occurring in fact. Then you can see signals like this, you see it is like the haywire, it is everywhere, right. So, this is the case when epilepsy or seizure occurs, and the importance of classification. Why it is important to classify epilepsy is because type based treatment, the most immediate influence on the therapy, what kind of medicines can be given, what kind of therapy can be given, can be decided by us, by a doctor once a person knows that what kind of epilepsy is there. Second is the classification system is also used to identify which patients are most likely to benefit from surgery to treat their epilepsy, as well as type of surgery that is needed, because like I said, in certain cases there is something called intractable epilepsy where it cannot be treated by taking the drugs, and in that case a person has to go for surgery, and epilepsy classification would help to know that what kind of surgery is needed. Next one is, if the doctor fails to recognize the syndrome, another medicine may be prescribed that may make the seizures worse instead of better. Okay. So, that is extremely important, this point is extremely important if you just have read it, right. If the doctor fails to recognize the syndrome, and another medicine may be prescribed that makes the seizure even worse, right, and that is why it is very important to correctly classify the epilepsy. So, then if you want to classify epilepsy, you should know what kind of epilepsies are there, right. So, the first one is generalized epilepsy, then there is a focal epilepsy, there is a absence, and there is a focal to secondary generalized epilepsy. So, it is just an example of generalized on and focal seizure. So, this is a focal seizure, partial onset of seizure start in one part of the brain, and the generalized involve the entire brain, right. Everywhere the electrical signals will start misfiring, and in the case of the focal seizure, only a particular part of the brain starts these particular seizures. Okay. So, let us quickly understand and recall, if you remember about the EEG, right. EEG, single neuron activity produces two small signal. EEG reflects the summation of the synchronous activity of many neurons, right, because many neurons will bring together the EEG. We have learned this thing in a previous modules, right. It is difficult to detect signals from deep sources, subcortical areas, than the areas near the skull, and then we have seen that how the neurons will, one single neuron will look like, and then if you divide it or if you understand it, then there are dendrites, neuron body, axon, and synaptic terminals, and then we have seen this particular schematic where the 10-20 systems are placed on a person, right, and same way how 10-20 system is defined is right over here, right, and you can see that all the even number of electrodes are on the right side, odd numbers of electrodes are on the left side, right. So, this is something that we need to remember. Now, why I have teaching you the same slide again? Because now the data that you obtained from this 1020 system, the 21 electrodes is what we need to see. So, as you can see procedure, right, this also we remember, right, that how the systems are placed, 10-20 percentage way and 21 electrodes are there, and we can use wet electrodes or dry electrodes. So, this is an actual photo of a person recording the data from a patient. You can see all these electrodes are used to acquire the signal. This is the signal that is acquired from these electrodes, and this is another image, right, that you can see all the signals from 21 electrodes are acquired. EEG is recorded for 30 to 45 minutes using 1020 system. Subject is asked to come sleep deprived, and experiment involves where to place the electrodes, how to check the impedance, because wet electrodes would have different impedance than dry electrodes. To improve the impedance or reduce the impedance, in fact we use gel, and that is why wet electrodes uses gel to reduce the impedance. Then you have photic simulation, you have eye open closed, you have hyperventilation, and you have sleep when you are resting. So, the outcome would be seizure detection, classification and type based medications. Okay. So, what you see now, in internationally 1020 system is recognized. So, we place the electrodes and we can take this electrodes from the signals from different region. When you have that, then multi-channel EEG, you can have acquisition module pre-processing and then ID based seizure type detection classification, right. So, this is before it, then once we process it, post processed data. Now, depending on that, you can either say the subject is normal, or there is a focal seizure only in certain region, or is a generalized seizure all the regions, or spike wave discharges and absent seizure, okay, like waves you can see here, like, so the waves are there. So, it is spike waves. Okay. So, now we know, okay, then if it is just one particular region, it is a focal, right, it is everywhere, it is generalized with spike waves and absent seizure. Okay, great. So, what to do with this, right. Now, if you know that, okay, these are the possible feature extraction parameters, that means that we know that there are spikes, there are sharps, slow waves and spike waves. Okay, these 4 feature extraction things are there, but how we will determine from this signal whether there is a spike or slow waves or there are sharps, right. So, then the literature, right, it is not what we have done in the lab, but the literature shows that the spikes can be defined when the time duration is between 20 millisecond and 70 millisecond, where the amplitude is greater than 20 microvolts. The frequency is between 14.3 hertz to 30 hertz. These sharps are defined when the time duration is between 70 milliseconds and 200 milliseconds, and the amplitude is greater than 20 microvolts, while the frequency is between 4 hertz and 14.3 hertz. While the slow waves are defined as the waves that are having time between 200 milliseconds and 400 milliseconds. You can see it is increasing, right. Spikes 20 to 70, sharps 70 to 200, slow waves 200 to 400, everything amplitude is greater than 20 microvolts, and here the frequency is 2.5 hertz to 4 hertz. Okay. So, frequency is in a way decreasing, right, or is a different frequency range, 14.3 to 30 hertz, 4.4 hertz to 14.3 hertz, 2.5 to 4 hertz, and here is an actual representation, right, of the EEG data, right, extracted using the 1020 system, and you had just taken data from one particular group, right, which is your C3 channel number C3 for about 20 seconds, and you can see that the first one, which is the A, right, this one, right, is nothing but a raw EEG signal. Now, second one, this B one is your pre-processed signals, and the subsequent extractor traces depicts C is spike, right, spike 70 milliseconds greater than 20 microvolts 14.3 to 30 hertz spikes. Slow waves because it is between 200 and 400 milliseconds, right, greater than 20 microvolts and 2.5 hertz to 4 hertz. Sharps because we have 70 milliseconds, 20 and 70 milliseconds, sorry, 70 and 200 milliseconds. You can see here the little bit difference in the spikes, and then you have 4 hertz to 14.3 hertz is a frequency. And then you also have something called slow wave discharges, right, slow wave discharges. So, you have waves and it is discharged through the brain. So, this all is nothing but the electrical signal. Okay. Now, whether we put it in this form or you form in this form, actually whatever we are measuring is through this particular signal, which is B here. So, the pre-processing algorithm and the post-processing algorithm is very important. Now, if when we did that for lot of subjects, about more than 80, what we found is that if we put the channel number as x axis and the spike sharps and spike wave count in the y axis, then now you know, right, how we can calculate. So, then we found that the sharps on the right side of the or right channels and the left channels, right, along with the spikes and spike waves, right, can be very distinctly seen. You can see very distinctly it can be seen. Of course, the sharps are a little bit larger, the counts are more, but so is the spikes and spike waves. But in case of generalized seizure, we were not able to see any spike waves or spikes, only sharps were observed, right, and also uniformly. You can see on the right side, left side, kind of uniform. So, this is what we call as a generalized seizure, when the spike waves and the spikes are not observed. But when we observe all three things, spikes, sharps and spike waves, we called it as an absence seizure. Now, another thing that we observe is that if it is focal seizure, then only sharps and spike waves will not be there, but sharps and spikes will be there, and that too also predominantly on the left side or a right side, is to not be uniformly distributed like in the case of the generalized seizure. So, based on that and based on number of counts, we can say that it is a focal seizure. Finally, for the normal subject, we were not able to identify any kind of the feature extractions, either it is a spike or sharps or spike waves, nothing was significant in case of the normal subjects, right. So, now if we know that it is normal subject versus a subject suffering from epilepsy, then using the 1020 system we can differentiate whether a subject is suffering from a generalized seizure, absence seizure, focal seizure, or subject is normal. So, this is extremely beautiful plot where you can see that for generalized epilepsy, all the electrodes are kind of increasing the number of counts. So, cumulative spike counts as well as spike and sharp counts are increasing uniformly. But in case of the focal seizure, only a few electrodes subsequently increases, all the electrodes are more or less uniform. So, the key observation is general epilepsy starts from the midline electrodes CZ, FZ and PZ, while the focal epilepsy however starts from either left or right side of the of both the electrodes. So, now like I said, we have done extensive analysis from lot of subjects, and what we found is that the seizure type classification of our algorithm was close to 93.18%, that means 82 out of 88 were correctly identified. Let me also tell you that all normal were identified as normal only, and that is a good thing. Only for generalized we missed 1, and for focal we missed 4, and for absence we missed 1. Right. So, that is the performance of the algorithm. We are working on improving it, and the overall F1 score was 0.9381 and MCC was 9.9059. We have also done blind validation which resulted in 90.91 accuracy, where we were not knowing that what kind of subject is there, and our algorithm predicted that this subject suffers from so and so seizure, or the seizure can be it is absence or focal or generalized or normal. As I was telling you that we have published this paper in biomedical signal processing and control, and this it on nothing but spatiotemporal analysis of interictal EEG for automated seizure detection and classification. And you can, and also we have filed a patent, because I will tell you the reason of this patent, because now we can use the algorithm and can aid the clinician to quickly get the diagnosis done. Of course, this was in press release and all these things, but the point is that if you have this kind of seizure classification algorithm, right, and you know that how to measure those EEG data, right, then you can very easily help a clinician or aid the clinician to come up for faster diagnosis, or also to save the time. Now, one thing that I have not told in this particular slides is that not only the algorithm was able to classify the seizures or seizure type, but also was able to tell the clinician which timestamp to go. So, not only saving the time, but also helping which kind of seizure is that, right. So, both things in one go. Of course, the data is not that great, because or the performance is not that great, because it is 90.91 when we are looking at the blind study. It should really be very high. We are optimizing the algorithm, but my simple point is, knowing the EEG, understanding the EEG, you can help to fill a very important gap in the area of epilepsy detection. So, with that we will stop this lecture here. We will continue with the epilepsy and the how to understand the anti-epileptic drugs and its efficacy by using a microelectrode array. We will see in the next class. We will see how the fabrication of this microelectrode array is done, and how we can acquire the signal. Till then, you take care. If you have any questions, feel free to reach us through the NPTEL forum. I will see you in next class. Till then, bye for now.